It's a pleasure to be here, and I thoroughly enjoyed my 2 years in Penang, and enjoying my holiday back here now. My wife's not down in Kuala Lumpur today. She's got commitments in Penang, so she's still there. I've become very involved in the medico-legal side of cerebral palsy because in the last 12 years I've done about 1,200 reports of a variety of sorts on medico-legal matters. The commonest would be cerebral palsy, and there's about 100 cerebral palsy cases that I have been asked to look at and to consider, is there something that could have been done that would have prevented this or modified it? And that's the sort of questions that one is always asked. So if we go into this and just bottom right. This is what? They're all different. Okay. So I've entitled this "The Role of the Obstetrician in Preventing Cerebral Palsy and Protecting Oneself from Litigation." Very, very important that you basically follow the sort of things that I'll be talking about. Some important facts about cerebral palsy, many of which will be well known to you all. Overall incidence, about 2 in every 1,000 births. Most countries of the world have it about that. Hasn't really changed since obstetric care has changed. Hasn't changed since there's been monitoring of women with CTGs, monitoring babies with CTGs in labor. Hasn't changed despite the fact that caesarean section rates gone from 6% when I was a trainee to 30% of the Royal Women's Hospital now in Melbourne. It's changed a bit because we're now keeping little babies alive, whereas they all used to die. It's changed because there are more multiple pregnancies, but apart from those, it really hasn't changed a great deal. It can be due to genetic problems, relatively rare, but not rare. It can be due to a problem during the pregnancy, antenatally, most of which are not recognised and not able to be recognised. It can certainly be a problem due to a problem in labour, particularly hypoxia, or even a problem within the first couple of years of life, when in fact an infection, a meningitis, or an encephalitis can certainly result in the equivalent of cerebral palsy. If we look at the intrapartum ones, they're generally believed to be the cause in about 10% of cases. So if there's 2 in 1,000 incidents, it's about 0.2 in 1,000 due to a potential problem in labour. And it's about 0.1 in 1,000 if you take things that you could have done something about in labour. Because you're faced in many instances with, say, a big placental eruption or a cord prolapse, which was completely unexpected, where there's time taken to get those deliveries done, where not much else could have been done to have prevented. So that's basically a few of the facts about cerebral palsy. High payouts are common, where inadequate care has been defined by the courts. And that really depends on the calibre of the lawyer who's involved on both sides. And the lawyers acting for the plaintiff will try and blame the doctors so that they get a good payout for the patient. And the lawyers for the hospital or for the doctor concerned will obviously try and do the opposite and say this could have been due to a whole host of other things, or we did things as fast as it was possible to do. The largest claim in Australia currently is 16.2 million. I've reversed that. Yours was 5.4 million ringgits a couple of years ago, unless there's been a bigger one since then.
Well, that was last year, 5.4.
Last 5.4 million. So you're dealing with a problem that's not as expensive as in Australia, because 5.4 million ringgits is only a tenth of what it was in Australian dollars. But you know, it's certainly a significant problem, and it's one that we would worry about. So, in looking at this, I want to cover the sort of things I would look at generally if I saw a case of cerebral palsy and was asked to comment on the care that had been provided. I'm going to look at the causes of neonatal encephalopathy as defined by Badawi in 1998. She lives in Western Australia. She was heavily involved in cerebral palsy work there. Beautiful data on neonatal encephalopathy. Is that cerebral palsy? No, it's not. Are there a whole host of causes of neonatal encephalopathy? Yes, there are. Some are genetic, some are infective, some are hemorrhages, some are intrapartum hypoxia. And if it's intrapartum hypoxia that's the cause of that encephalopathy, and not hypoglycemia or hypomagnesemia or hypocalcemia, then that's more of a worry. And you need to bear that in mind when you're dealing with this particular problem. I'm also going to be talking about a recent publication that came from Alistair McLennan's group in Adelaide. And Alistair's been very heavily involved in the whole problem of cerebral palsy, and was the first group to give you a consensus statement on intrapartum hypoxia. The second study then came out of the American College and the American Academy of Pediatrics, and I'll refer to both of these in my presentation. International consensus statements, and that's what they are. And lastly, what methods should you be using to try and protect yourself from the whole problem of litigation? Badawi looked at a whole host of things, and she said, yes, for genetic factors, for neonatal encephalopathy, seizures are important as far as the family history is concerned. Family history of nervous disorders is important. This is the relative risk. If it's above 1 and the percentile limits don't go below 1, then in fact it's significant. And this was family history of seizures, the relative risk was 2.55. Family history of nervous disorders, again, there. Coagulopathy, no doubt. What about antenatal risk factors that she described? And this is going back 1998, before the consensus statements. And she said, well, if they've had a viral illness, they're at 3 times the risk. Severe antepartum hemorrhage, moderate one, 3.5 times the risk. IUGR, look at that, 3rd percentile, 38 times the risk. A big problem. If you have a baby that's growth restricted, then clearly, if you can recognise it early enough, you have to make some decisions, and I'll refer to some of those. Previous infertility treatment also was a relative risk that was in a significant group. Severe preeclampsia, thyroid disease, monochorionic twins, and there's debate about that. She didn't give data on reduced fetal movements or death of a baby, a twin, but that has been provided by others. She also described the intrapartum problems. Intrapartum fever, occipital-posterior presentation. I always used to teach the students that if you're dealing with someone with an OP position, their incidence of fetal distress is higher. They have an incoordinate uterine action, their intrauterine pressure is increased between contractions, there's less placental blood flow. Clearly that would be a factor here. Intrapartum hypoxia, not defined as a cause in that publication of hers. Elective Caesar, lower risk, 1/5 of the risk of a vaginal delivery. Emergency Caesar, depends on why you do it, but it's still higher than you'd expect. And general anaesthesia for delivery, again, probably done today because of problems that necessitate urgent care. If you deliver them prematurely, then she described a number of things, and the risk of a term delivery was about 2 in 1,000. That's the incidence of cerebral palsy. If you deliver them before 28 weeks, it's 38 times that. If their birth weight is low, it's again 25 to 40 times the incidence which we would expect in the population as a whole. I put this together about 2 years ago, and in fact I said at the time, if we believe the 24-week survival in Melbourne is currently getting close to 50%, and if 20% of them are going to have cerebral palsy, then you've got a high incidence, a very high incidence. And those figures aren't far from what you'd expect in looking at the figures today. And now, in many parts of the world, we're attempting to get 23 weeks to survive. And the incidence of cerebral palsy in that group will probably be even higher. What about multiple pregnancies? And this was data published in 1993 in the BMJ by the same group from the Western Australian Institute of Child Health. The 10-year intake, 220,000 births, 5,000 from twins and 237 from triplet pregnancies. And look at the data on cerebral palsy. Right-hand column, single pregnancies, 1.6 per thousand births. Twins, 7.4. Triplets, 26.7. And that's not just mode of delivery. And it's not just the gestational delivery. It's the triplet pregnancy and the twin pregnancy with all of its potential complications. And I can vividly remember one of our own patients at the Women's Hospital, Dr. Shelton looked after many years ago, a private patient of his, triplet pregnancy, and he delivered her electively at 34 weeks by caesarean section. All three babies got cerebral palsy. They didn't have a label, there was no intrapartum hypoxia, but all of them had cerebral palsy. So in general terms, what's the risk in a multiple pregnancy? It clearly depends on the number of fetuses. They're often delivered prematurely, which complicates it. Their weight is therefore low because of their premature delivery and because of the increased risk of intrauterine growth restriction, which clearly accompanies it. And there's plenty of data now telling us all how we should manage multiple pregnancies, whether they're diamniotic, dichorionic, etc., or monoamniotic or monochorionic. And certainly the monochorionic, monoamniotic are bad, and most people would say you should be delivering them electively by caesarean section after steroids, probably around 32 to 34 weeks. The diamniotic, monochorionic, they're worse than the other twins, but they're not nearly as bad as the monoamniotic. And the risk of these is basically twin transfusion syndrome or fetal death of one. And if one dies, and it's a monochorionic twin pregnancy, it's highly likely the products from that twin will get into the other one and cause long-term problems. High incidence of cerebral palsy. What about the vanishing twin? Do we need to worry if a twin dies very early? You know, we're now living in a society where there's lots of multiple pregnancies associated with the use of IVF, where the first ultrasound is done at 6 weeks to make sure that the pregnancy is in the uterus, and where twins are often diagnosed. And by the time it's repeated at 11 to 12 weeks, when they have their nuclear fold assessment done, if there's been twins found initially, often it's down to 1. And there's considerable debate as to how many of these are actually lost when we're defining them so early. And with IVF pregnancies, it's now being described as being up to 85% of them finish up as only 1. There's no real good data for twin pregnancies that are not IVF created to give you the same information. But of course the IVF ones are automatically at greater risk because of the well-known abnormalities in terms of their genetic constitution in that group. But it's a problem. And, but what we can say is that there doesn't seem to be an increased risk of cerebral palsy with early loss of a twin fetus and coming back to only one fetus remaining. This is the second study that's been published on antenatal problems and cerebral palsy. And this is McLennan's study from Adelaide, just published within the last 12 months in Obstetrics and Gynecology. A good journal, a difficult journal to get publications in because they're very tough. And I would think that if it's been accepted by them, then it's data that you ought to be prepared to accept. There are always some problems with publications, particularly in this area. I don't think there are major problems with this one. They had 587 cases of cerebral palsy and 1,154 controls. But they then contacted all of these patients and asked them a whole host of difficult questions about the care that they'd received, the problems that had occurred during the pregnancy, etc. And they did the same with the controls. And their cerebral palsy varied with the different sorts of cerebral palsy you see that would in some instances be related to intrapartum hypoxia and other things. They looked first at infection, being discovered by Badawi, and therefore there was concern. Any infection associated with an odds ratio of 1.71 clearly didn't go over the 1 back into less than 1, therefore it was significant. But what was of interest is that prior to this study, Alistair had been telling people that if they get an infection, even just a cold, they're in strife. This study showed that that was wrong, that the common infections that pregnant women get, upper respiratory tract, gastrointestinal and urinary tract infections, all of these were not significant in terms of the incidence of cerebral palsy, ultimately in the babies. But herpes in the early pregnancy, fever in the latter half of pregnancy, infection in labour and delivery, big problems, very significant, and certainly are of some concern. And as obstetricians, we must be aware that in fact if there is evidence of infection in those areas, you need to therefore ask yourself, should I be doing more? If so, what? What about birth weights and cerebral palsy? Again, the original study said if they're under the 3rd centile, you're in strife. This study confirms that, less than the 3rd centile, relative risk 11 times the normal risk, where in fact it's less than the 3rd centile. Lesser risk at lower weights, and in general terms one would say anyone who's under the 10th percentile is certainly at increased risk. After that, less of a problem, but still potentially some sort of problem. What about other associations? And they looked at gestation at delivery and compared less than 32 weeks with more than 36 weeks, 70 times the relative risk. Delivery 32 to 36 weeks and greater than 36 weeks, still significant, but not as obviously significant. Twins worse than singles. Breaches worse than cephalic. Overall, even expect, didn't matter how you delivered them. Vaginal breech delivery, 8 times worse. Emergency caesarean section for a breech in labour, 4.5 times worse. Even elective caesar for a breech, increased risk of cerebral palsy. There's something already wrong with those babies if they're presenting by the breech, potentially, neurologically, as a reason for their breech presentation. And clearly, you need to be aware of that. And of course now, with the Canadian study, the question is, how should we be delivering our breeches? Should we be caesaring them all? And we basically do in most hospitals now. Although some people are moving back to a planned vaginal delivery if they labour on their own, they labour before 40 weeks, and it's a breech with extended legs or a complete breech. It's not the same degree of must have a caesar, quite as there was even 10 years ago. But you're in practice and you'll be well aware of that. What about disappearing twins? In their group, no evidence that in fact that was a problem. It wasn't significant. Look at bleeding in pregnancy. Very common. Yes, it is. If they bled in pregnancy, and they didn't state whether this was first trimester, second or third, double the risk. 3 or more miscarriages as compared to no miscarriages in the past, yes, they are at increased risk, as patients are with drug use, smoking. And of interest, the male sex of the baby was more important than the female sex for determining whether that child was going to get cerebral palsy. And the others that they looked at and that they commented on, APGAR scores, 20 times the risk of their APGAR score at 1 minute was less than 4 as compared to greater than 8. 50 times the risk if at 5 minutes those levels still apply. Emergency caesarean section compared with normal vaginal delivery, twice the risk. Elective, really just got over the 1, only just. So this is data now which we've got in terms of fitting in early neonatal life and in terms of real cerebral palsy definition and underlying potential causes. What about intrapartum? what is the evidence that is real proof that in fact intrapartum hypoxia is the cause of the problem in this baby that's got cerebral palsy. And McLennan's group published this in 1998, 1999, and there's a second publication that came out from the American College of ONG and the American Academy of Pediatrics. And I'll refer to them both in the same set of slides because they are almost identical and just give you the differences between them. Evidence of metabolic acidosis. You've got to have that. It requires either a scalp sample done intrapartum or a cord arterial or an early neonatal blood. And in each of these studies, they said the pH, if it was indicating intrapartum hypoxia, the pH had to be less than 7 and the base deficit greater than 12 millimole per litre. It's of interest that in fact the American College and the American Academy of Pediatrics said that we can't take any notice of the scalp sample. We really can't take any notice of the early neonatal blood sample. Because if there's been good resuscitation of that baby, then you may well have reversed something which was much worse at birth, and you're really then underestimating it. If they, in fact, have poor resuscitation, then it's the resuscitation after birth that's a problem. It's not the intrapartum hypoxia. Therefore, the American Academy and the American College said it's got to be a cord arterial sample which you've got. And if it's anything else, we're not interested in it. And you'll see, in fact, different lawyers taking different attitudes in terms of that. The second essential criteria, apart from that as proof, was early onset of severe and moderate encephalopathy. Early onset meaning that they have their first episode of seizures within 2 days of birth. Somewhere between 12 hours and 2 days of birth. An essential criteria. And the third is that the cerebral palsy has to be spastic, quadriplegia or dyskinetic in type. And those were the 3 essential criteria that McLennan's group defined. Yeah. And that was an international group who were involved. The American College put in the 4th one, exclusion of other etiologies such as trauma, coagulation disorders, infectious conditions, genetic disorders. Otherwise, their essential criteria were identical. And that's what the lawyers have to argue about in terms of this particular proof or disproof of intrapartum hypoxia. There were also 5 non-specific criteria for diagnosis. Non-specific because they could be due to other things, but they're more likely to be due to hypoxia, certainly if they're all present. And they were that there really was a hypoxic event, a sentinel event, before or immediately after labour had started, an antepartum hemorrhage or a cord prolapse. 2, there was a sudden, rapid and sustained deterioration in the fetal heart rate pattern, usually after a sentinel event, in which the fetal heart rate was normal prior to that. Now, they didn't define which heart rate problems were the most likely ones, but the American Academy did, and they said it had to be a sudden and sustained bradycardia or a complete absence of fetal heart variability in the presence of decelerations. So in fact, CTG enabled people to look at it. If there were good accelerations, if there weren't decelerations, you didn't need to worry at all. And for practical purposes, what they have said, as I'll get to this in another slide, is that if there's no beat-to-beat variability and it's just going along with no variability at all, then that's a real worry. If they have a prolonged deceleration at the end, so that it's down below 80 and remains at below 80 for 5 or 10 minutes, then that's a big worry. But the decelerations that are occurring after every contraction, even if they're variable decelerations are coming down to 60 and getting back up again, don't indicate this baby's likely to get cerebral palsy. The persistent late decelerations don't indicate cerebral palsy either, unless they're associated with lack of beat-to-beat variability or ultimately a prolonged deceleration. As clinicians, we need to worry as to how they'll progress. but they'd have difficulty in a court of law in Australia saying that this is the cause of cerebral palsy if there hadn't been these two problems: lack of beat-to-beat variability or a prolonged deceleration. The Clemens group initially in 1998 said APGAR score less than 6 for more than 5 minutes. The American college said 0 to 3 for more than 5 minutes. Evidence of multi-system involvement. Yes, they have to have involvement of other systems. It may well be a coagulopathy, it may well be renal compromise, it will be respiratory compromise requiring respiratory support, all of these. And the last was early imaging evidence of acute cerebral abnormality. It needs to be non-focal, and it must entail at least ultrasound examination of the brain looking for evidence of edema. It must also, or should also be, either CT or MRI assessment looking for the damage to the different parts of the brain which one is likely to see in association with hypoxia, particularly periventricular recoagulation. So you've got to get those things done. No point doing your ultrasound on the day of delivery. They won't be edematous then. It's got to be a day or two later. Probably you should be getting your MRI done on about day 5 of life. Although if you get it done earlier and it shows an abnormality at the very early stage, then that would indicate to you that in fact this problem occurred well ahead of labour. And the paediatricians clearly need to be aware of the timing of these evaluations to ultimately assist you and them if in fact the child is ultimately shown to have cerebral palsy. Just a little bit more on the CTG abnormalities. Here are the facts. Moderate fetal heart rate variability strongly associated with an umbilical artery that was in the lower part of the normal range, greater than 7.15, not the less than 7, which is believed to be the factor associated with proof of intrahepatic hypoxia. Undetectable or minimal fetal heart rate variability in the absence of late or variable decelerations was the commonest predictor of ischemia and acidemia. But only 23% of them who have that actually do show evidence of acidemia. The other 77% don't have that evidence. The CTGs obviously are worried, but they're not hypoxic and acidotic at birth. Strong relationship with the degree of acidosis and the depth of decelerations or bradycardia. But except for that, due to a sustained and sudden bradycardia, the others had to be persistent for a much longer period to produce an acidosis. And it needed to be about an hour of decreased fetal heart rate variability if in fact that was the only problem they had. Only CTG abnormalities associated with cerebral palsy as described by Dr. Nelson were those of recurrent, late or prolonged decelerations or profound loss of variability. And as you would be aware, almost all of our patients, if they're monitored with CTGs in labour, do have some abnormalities, most of which are significant. I think we all work in hospitals where a lot of midwives are involved in care, and the midwives tend to not worry about a patient who's been having labour induced unless the CTG is abnormal. It's almost that they don't look at the contraction frequency. They just look and see whether the CTG is normal or abnormal. And I've seen many CTGs where it's been belting along at contractions at a rate of 6 in 10 minutes, where the CTG is still normal for another half hour or so, and then it becomes abnormal, when the whole of the process should have been turned back a lot earlier. And I think we all have a responsibility to ensure that when we're on for late ward duty, we're following rules that in fact will reduce the likelihood of hypoxia due to the induction process, which is clearly not without risk. If you define hypoxia on those various parameters, the essential or the other parameters, then you've got to ask yourself, was there a sentinel hypoxic event, and could you have done anything more quickly or done anything about And if you're giving a medico-legal report, clearly you need to do that. You then have, what was the duration of the hypoxia? How long did it last for? Could it have been dealt with more quickly? Was there an intervention available proven that you could have used to shorten it? Could the signs of fetal compromise in labour have been detected earlier as part of this whole problem of recognition and dealing with it? And was there an avoidable delay in expediting delivery once fetal distress was defined on clinical grounds or on CTG grounds? And if it is defined, would quicker delivery of the baby have compromised the mother's life? If that's the case, then you may well have had another factor you had to take into account. Would an earlier delivery, if practical, have prevented or ameliorated the outcome? Often, when you're looking at a case of cerebral palsy, you can't say what the answer to that question is. All you can say is that, in fact, this hypoxia went on for about 20 minutes towards the end of labour. If they'd been able to get the baby out more quickly, would it have been any different? Possibly. No absolute proof in many instances that that's the case. Are there any additional investigations or assessments required? And I've already indicated that you clearly need to speak with your paediatric staff about the timing of the investigations that they're doing to give you the best information to pick up whether there is any evidence of intrapartum hypoxia or whether there's any evidence of a problem before labour that would be clinically, it would be evident on radiological evaluation if done at the right time. We're still seeing cases of cerebral palsy in Australia where, in fact, the baby was delivered in the late 1980s, where none of these investigations were then readily available, and people were trying to make decisions on what the cause was. What are the general things that are labelled against the obstetrician? Inadequate fetal heart rate monitoring. Why didn't you use a CTG? Why didn't you use it continuously throughout the whole of it? Gee, I worked in Penang. Every patient has a continuous CTG through the whole of labour if they're in Penang General Hospital. The Royal Women's Hospital in Melbourne, it's about half. Up until 12 months ago, they all used to have a CTG at the time of admission, and that determined whether they had a CTG throughout labour. It's clearly been shown that admission CTGs are of very limited value and reported in the literature in the last couple of years. What should you do? I don't think there is a clear answer. Many patients don't want continuous CTG monitoring. If they're high risk, they should have it. They certainly should have it if they're being induced. If they had a dose of prostaglandin as part of their induction process, then they should certainly have a CTG during labour, and you should be watching the frequency of their contractions, because they often get excessively strong contractions and excessively long contractions, too frequent. Second criticism, you should have done a Caesar. It's always easy in retrospect to say, yes, I could have done a Caesar earlier. But prospectively, when you don't know what the end results have been or are going to be, it's much more difficult. Delay in expediting delivery. Why did it take you 40 minutes to get this baby out? Inadequate resuscitation. You didn't have a paediatrician there at delivery. Do we need a paediatrician at all deliveries? No. As obstetricians, are we trained to resuscitate babies? Yes. And we should be able to at least resuscitate them to the extent of keeping them alive and giving them some oxygen and some vascular support if necessary, at least until the paediatric staff arrive. But we don't have to have them there the whole time. What would adequate care be then in various instances? Certainly, we must inhibit prematurity. I've already given you the data on the incidence of cerebral palsy in various birth weight categories, etc. If you have a choice, you certainly would try and inhibit the lot, fill them full of steroids, and certainly now people would say you probably ought to give them magnesium sulfate as well, but I'll get to that in a moment. Look for evidence of chorionitis after a premature preterm premature rupture of the membrane does occur. If it occurs, the risk of cerebral palsy is clearly higher. If they become febrile in labour, what should your attitude be? Do you have a cut-off point? Do you say if the temperature is below 38, well, this is probably just labour, or the effect of the epidural, or the induction process that you use? Or do you give them all antibiotics if it's above 37.5? There's no rule around the world for that. If the membranes have been ruptured for more than 18 hours, most people would give antibiotics. If you screen them for group B streptococcus, we would give them antibiotics. You won't pick them all. And there'll be occasional cases of group A strep that will get in and often be worse for the mother than some of the other infections. But look for it, treat it. You're much better off treating it until you know that there's no infection there, and then stopping your antibiotics subsequently. If you've defined severe intrauterine growth restriction associated with a massive increase in cerebral palsy, how long can you leave them there? And how would you deliver them? Most of those would be, in Australia, delivered by cesarean section. And once they're beyond 32, 34 weeks, decisions are made to expedite delivery rather than keeping them in utero, although there is some debate as to whether you are putting them at increased risk by keeping them in utero. Adequate fetal monitoring in all risk cases, and that could be ultrasound, CTG, Doppler studies, all part of sophisticated antenatal care today. Lean towards caesarean section delivery in higher risk cases. The Caesar rates are going up. I was speaking with someone here earlier tonight. Caesar rate of 35%. Caesar rate at the Women's Hospital in Melbourne is 30%. In the private section of the Women's Hospital in Melbourne is 50%. They would say it's because we're getting all the difficult ones sent privately because of the problems they had last time. That's not the only reason. But clearly you need to decide how to do it. What care should you give if there are multiple pregnancies? What's the place of special care in them? And it's clearly defined. What about magnesium sulfate? And this is a study that was reviewed just a couple of years ago. Women's hospital staff were involved where they looked at patients who were given magnesium sulfate and did it change the incidence of cerebral palsy? And the answer is yes. It reduced it to about 0.68 of a relative risk that we were otherwise seeing. And now anyone labouring before 30 weeks, as part of their treatment, or if they're just going to be delivered early because they've got a severe preeclampsia or something like that, and they're going to be delivered around 30 weeks, they're given a 4-gram loading dose of magnesium, 1 gram per hour for 4 to 24 hours, and then the delivery is expedited. All on that particular basis, and it's now being shown elsewhere as well. Ensure the CTG monitoring is used in labour. If you're inducing them, if you're dealing with preeclampsia or a previous APH where the incidence of fetal distress is high. If they're diabetic, even if they're just gestational diabetic, you certainly should be monitoring. If they've clinically got intrauterine growth restriction, meconium staining, use of syntosine, prostaglandin, or the use of epidural. No debate really about any of those, and you should be using them continuously until they're delivered. Prostaglandin inductions are great. So much better than what we did have available before, but they're not risk-free. Prostaglandin certainly increases the risk that if you have to give syntosine as well, you'll finish up with overactivity of the uterus. And some of them will finish up with that overactivity even if they're not being given syntosine. Be careful. You're much better off to take it slowly if you can. Turn off the syntosine if the CTG becomes abnormal. And I would add to that, if the contraction frequency becomes greater than 5 per 10 minutes. Some people would say greater than 4 per 10 minutes. How often do patients labour any more frequently than every 2.5 minutes and have their contractions any more frequently than that if they're doing it all on their own? Why should we push them to the extent of really pushing the likelihood of distress up into a much higher level? If the second stage becomes prolonged, You need to watch them carefully. It means listening to the fetal heart between contractions, or preferably just using a CT tube. Ensure minimal delay when delivery is required. Assess the scalp pH or lactate in stage 1 of labour if you're possibly hypoxic, so you know whether you should continue. And if possible, have a paediatrician there. Don't try and find one later. What about the delay which we see in expediting delivery? How bad is it in major hospitals? And in Australia we divide them into 3 levels. Level 3 are those hospitals with sophisticated obstetric care and sophisticated paediatric care, neonatal intensive care units. The big hospitals. In Victoria that would be the Royal Women's Hospital, Monash Medical Centre, and the Austin Hospital where the Nursing Hospital is. Only 3 of them in the state. Yet look at the time it takes them to get babies out, even when urgent delivery was required. The median time in level 3 hospitals was 42 minutes, with a range between 17 and 86 minutes. If you're in a level 1 hospital where you have to call staff in, and that's anaesthetist, paediatrician, nursing staff, set up the theatre, get everything moving, then in fact it's even longer. A median of 69 minutes with a range of up to almost 2 hours. And this data has now been produced in a number of cases in Australia where the patients have complained that the baby wasn't gone out in under an hour. To show you that in this data that's come from Australian hospitals, the time interval between decision to actual delivery is often much longer than we think, for a variety of reasons. If they looked at the reason for the caesarean section, again in level 3, non-reassuring fetal heart rate, the median time was 43 minutes. Abnormal pH, less than 7.2 would be the regular one, 33 minutes. Failed forceps delivery or failed von 2s, shorter because a lot of those are being done in theatre anyway, as a trial of forceps or a trial of von 2s, where people were concerned that it mightn't be going to be successful. Still 21 minutes to get them out. Cord prolapse 28 minutes and antepartum hemorrhage longer. So babies just aren't got out quickly in all instances, and in many hospitals it's related to the time that it does take you to get the theatre organised and get all the staff in. Forceps delivery ought to be faster. Right? You've got to do a PV to determine the position of the head, insert your anaesthetic if there's not an epidural already in, place the forceps accurately, and then apply traction. Mid-forceps deliveries today are much less common. Much less common. And it takes a fair while to do a vacuum extraction. Longer than it would take me to do a mid-forceps delivery. But in the younger generation, most of them are doing vacuums rather than forceps. And it takes longer. Because there's delay taken to create the vacuum, not as long as we used to have, where it took about 5 to 10 minutes to create the vacuum to the appropriate degree. Now you're able to do it more quickly. Traction only with contractions always takes longer than forceps, and often the cup becomes dislodged. And it should be all over in 20 minutes. Although I saw a case recently where the total duration of the vacuum extraction delivery done by a GP took an hour, with the vacuum cup on the head for the whole of that time. If that goes to court, I think I know what the result would be. So as an obstetrician, what is your role at the time of delivery? Clearly you've got a problematic question of care antenatally. Clearly you've got to think about care intrapartum. Does your responsibility stop then? No. If you're there on your own, you've got to do some of the resuscitation. You certainly ought to be quickly clamping the cord. And if the APGAR scores are low, or there's a real reason for suspecting that this baby is at increased risk of cerebral palsy, as defined by all the factors that I've talked about, get the cord blood sample sent off, arterial cord sample sent off. If it shows the pH is greater than 7.2, whatever happens to the baby shows it wasn't related to intrapartum hypoxia. And we should be collecting cord blood samples in any patient where the APGAR scores are low at 5 months. And low, I would say under 6, certainly low if it's 3 or less. If the baby shows evidence of intrauterine growth restriction or low APGAR scores, get the paediatricians involved in the assessment, the further care, including doing other tests that these babies are more likely to need, and work out when the ultrasound and the MRI should be done. To give them the best information about the diagnosis and to give you the best possible support that you might ultimately need in terms of protecting yourself, or at least ensuring that if the case goes to court, that the data is there, and that all the data is there, and there's not great holes in your data. I trust that gives you something to think about.